is entitled Cross-Cultural Neuropsychology, Training and Practice Considerations. This webinar is jointly sponsored by the Society for Clinical Neuropsychology, Ethnic Minority Affairs, SCN-EMA, and the Association of Neuropsychology Students in Training, ANST. This webinar is hosted by Preeti Sundararaman, EMA student representative and clinical psychology PhD candidate at Drexel University, and myself, Octavio Santos, ANST liaison officer and clinical psychology PhD student at the University of Wisconsin-Milwaukee. Our webinar is structured into 5 sections. The introduction will briefly explain what cross-cultural neuropsychology is and its importance to our field. It will also describe our new webinar series. This will be followed by a presentation on multicultural neuropsychology clinical training, which describes a multicultural practicum as well as expected competencies and related issues. The next presentation focuses on multicultural neuropsychology practice. It will cover professional experiences from an early career neuropsychologist, as well as the steps to consider when setting up a service for ethnically diverse clients. Then we will have a Q&A session. You can submit your questions during the webinar by using the feature on the right side of your screen. Finally, links to the webinar's recording, materials, and a brief survey will be provided at the end. Now, it is my pleasure to introduce Dr. April Thames. Dr. Thames received her PhD in clinical psychology from Alliant International University. She completed her postdoctoral fellowship in clinical neuropsychology at UCLA, where she is currently an assistant professor in the Department of Psychiatry. Her research interests are in psychosocial factors that impact test performance among ethnic minority groups, the impact of infectious disease, substance abuse, and aging on neurological and cognitive functioning, and genetic predictors of cognitive outcomes. Her clinical interests are in neurodegenerative diseases, neuromedical illnesses, and comorbid psychiatric conditions. She's the director of the Neuropsychology of Medical Illness Practicum, as well as an internship and postdoctoral supervisor at UCLA. She's the chair for the Society for Clinical Neuropsychology's Ethnic Minority Affairs Committee. Now, I would like to invite Dr. Thames to take the lead by introducing our viewers to the field of cross-cultural neuropsychology and our new webinar series.
Thank you, Octavio. Welcome. Thank you to those who are attending this webinar. We are certain that you will find this webinar well worth your time, as we have been so fortunate to invite 2 amazing presenters that will be introduced in a moment. As some of you know, cross-cultural neuropsychology is an important subfield within clinical neuropsychology that has emerged over the years in response to the growing number of diverse populations in the U.S. There are many great papers that have been written by our colleagues in cross-cultural neuropsychology that highlight the many cultural differences, whether it be language, education, social factors, that often emerge in neuropsychological settings and can have great influence on performance. Recognizing that cognition is a construct that is undeniably measured through a cultural lens, the Society for Clinical Neuropsychology Ethnic Minority Affairs Committee, as well as the Association for Neuropsychology Students in Training, have identified a need to join together as committees and brainstorm a series of webinars that will address the more advanced issues in cross-cultural neuropsychological training and practice. And it's great to say that we can now get into the advanced issues because so many of our colleagues before us have paved the way to where we are at today. So rather than focus on normative data per se and education issues, because we feel there are a number of great position papers and educational materials out there to cover that, we want to focus on more of the applied nature of complex matters that tend to occur in cross-cultural neuropsychology practice. So we hope that you will enjoy this webinar. Please note that there will be a survey at the end of the webinar. It's very brief, promise, and it's very instrumental to helping to give us feedback about what we can do better and what you would like to see in the future. Please take the time to complete the very brief survey. We really want to hear from you. Thank you.
Thank you, Dr. Thames. ANST is very excited to work with EMA on this new webinar series. Next, we're very pleased to have Dr. Tedd Judd join us. Dr. Judd completed his PhD in clinical psychology at Cornell University and his postdoctoral fellowship at the University of Washington. He is a clinical and forensic neuropsychologist and cultural generalist with 30 years of experience in the Puget Sound area. He is adjunct clinical faculty in psychology at the University of Washington and Antioch University, and adjunct faculty in psychology at Seattle Pacific University. He has taught neuropsychology in 22 countries, including a Fulbright senior lectureship in Spain and 2 years of teaching in Costa Rica. His current research is about competence to stand trial assessments of immigrants. He is board certified in clinical neuropsychology by the American Board of Professional Psychology. He is also a fellow of the National Academy of Neuropsychology, a certified Hispanic mental health specialist, and past president of the Hispanic Neuropsychological Society. We would like to welcome Dr. Judd. Dr. Judd, please.
Okay, there we go.
There you
go. Okay. Thank you very much, Octavio, and to the entire committee for putting this all together, and to everyone else for attending. Next slide. My presentation will be divided into 4 parts, as you can see here. Next slide. And I realize that we have a number of non-native English speakers attending. We have an international audience. I understand that we have some people who will be viewing this later on YouTube from South Africa, which is because it's the wee hours of the morning there right now, but they are leaders in the development of cultural generalist neuropsychology, and some folks from Finland and elsewhere. And with non-native English speakers, I think I have to explain very briefly an English idiomatic expression. We often talk about, if you want to motivate the donkey, you can do it by holding a carrot out in front or beating the donkey with a stick. So we talk about the stick and the carrot. And I'm going to talk about justifications for multicultural neuropsychological training that way, and something else. Next. So the stick. It's very common to start these presentations, and I've done this many times myself, talking about the demographics in the United States, how we're becoming a more multicultural world, our professional ethics, the health disparities between minorities and majority populations, fairness, the legal mandates, and some of that is, you better watch out, you got to be up with your ethics, the immigrants are coming, uh-oh, we got to be ready. And I've done lots of those presentations. I'm going to skip over that for today. We will hear some of that from Melissa later on. I will just mention one point of that, and I'm going to move on to more of the carrot later on. Next. The one portion of that having to do with the demographics that I want to address is, why is it that, at least here in the United States, we're not seeing the non-native English speakers in our practices, in our hospitals, in proportion to their representation in the population. We see the demographics, but that's not what we're seeing in our clinics. And I hear that from lots of neuropsychologists in lots of places. Now, the following are just my impressions and opinions. They're all empirical testable questions. In many cases, the data are out there. I haven't dug it all up yet. But this is a thought piece for all of you. Next. First, non-native English speakers in the US are more likely to have neuropsychological disorders. There's lots of epidemiological data on that. More likely to have traumatic brain injuries, pesticide exposures, other toxic exposures, more likely to have strokes, and any number of other neuropsychological disorders, including some of the dementias. And yet that doesn't bring more of them into our offices necessarily. They're also more likely to seek out alternative approaches to these conditions and problems, and not just alternative healers, but other approaches entirely. Next. I don't mean to bore you by reading through all of these different ways in which non-native English speakers are less likely to arrive into our offices. You can take a look at all of these for yourself and check them against your own experience. But I would like to ask you to reflect on a few questions in contemplating these different reasons that such folks don't show up in our clinics. First question, how many of these things can be changed? I would suggest that actually all of them can be changed one way or another. Next question. How many of these are directly addressed by our professional ethics? I would suggest that, for the most part, that's number 12, number 15, and number 16. How many of these could be addressed by our professional ethics? I would suggest that if we chose to do so, it could be all of them. Although for many of them, that would not be our professional ethics as individual practitioners, but rather as a profession, as a society. Many of these have public education or political or policy solutions to them. So that's a piece for reflection. Next. Okay, the carrot. What are the positives of multicultural training? Basically, it makes us better neuropsychologists. In doing multicultural work, especially in a US context, and here I'm going to focus, I should say, on non-English speakers or bilinguals, especially bilinguals where English is their weaker language. And this is predominantly immigrant populations. In working with these populations, we get to do a lot of differential diagnosis work. We don't get to do that as often these days with majority populations who have often seen quite a few physicians before they come to us and have had a lot of workup and medical workup. But in work with immigrants, I find myself coming up with diagnoses that the physicians haven't found most of the time. And it's really intellectually exciting. It keeps you on your toes. It's part of the intellectual work that we're trained to do. You also get to see a lot of disorders that are rare in North America, and that gives you a broader spectrum, a broader perspective on brain functioning and on brain disorders. You get a broader understanding of the variations and the invariants in the manifestations of brain disorders. And so in that way, and in terms of improving our research, we also get to see and have a better idea of distinguishing what's brain function and what's cultural function. You get to learn about literacy and illiteracy and different kinds of writing systems and the impact they have on the cognitive process of writing. And you get a much deeper understanding of the principles of testing and measurement. Next. But there's not only the carrot. I like carrots, they're okay, but the ice cream, the really good stuff about multicultural work is it's really rewarding to do. In the first place, for those who have a second language and or a minority or cultural ethnic identity, it's a real opportunity to use that knowledge and those skills professionally and to serve your community, and that can be very rewarding. And for myself personally, I find this very rewarding because there are big challenges and there's great satisfaction in meeting those academic, clinical, and emotional challenges in doing this work. The clients are often exceptionally grateful because it's often hard for them to find that kind of understanding culturally and clinically. The professional camaraderie is exceptional, and the experience of working on this presentation with this committee has been certainly a very fun one that way. The listserv for the Hispanic Neuropsychological Society, for example, is very, very supportive. You get on some of those forensic neuropsychology listservs, you stick your toe in the water and an alligator comes up and goes for it. The other areas of neuropsychology don't have that same kind of camaraderie, but this is a supportive group generally. It's also a nice excuse to learn about other cultures, and there are various ways you can go about that. That's kind of an excuse, even though they're generally not billable or tax deductible. Next. I want to run quickly through a couple of definitions that we'll be using later that it's important to distinguish. Translators translate written language. Interpreters interpret spoken language. These are separate professions and skills, although there are certainly people who do both, but there are many who do only one. And the most succinct version I've had of describing the distinct cognitive skills is that translating is like chess, interpreting is like volleyball. When we as professionals confuse translators with interpreters, we sound naive to translators and interpreters, rather like how we regard things when we hear somebody else confusing a psychologist with a psychiatrist, for instance. And the other definition is sight translation is the process of reading a document or a test aloud in a language other than the language that it's written in. Next. Okay, I'm going to describe the cross-cultural practicum that I've been teaching for the last 10 years because it gives an example that I think may serve as a model in some ways for other people who are looking at doing this kind of training or trying to receive this kind of training. I'm hoping that there are a lot of supervisors out there who may give consideration to this, and I imagine there are quite a few students who may look at this as a way of asking for this kind of training from their programs. And I want to point out that I'm in private practice. Next. I'm a solo practitioner in private practice, and what I've done here has been pretty much on my own without institutional support or funding from elsewhere. And if I can do it, I think it's something that's probably pretty accessible to a lot of programs. The practicum is community-based. We're out in the community, as you will see. It's part-time. It's not a dedicated where I can guarantee students a certain number of hours a week. And many of my students are psychology students, not necessarily neuropsychology students. The assessments, however, are all neuropsychological in nature. And we're working primarily at administrative and forensic types of issues rather than clinical, although there is clinical treatment involved, clinical treatment recommendations involved in it. It's exclusively non-English-speaking clients, with some very few exceptions of a few Native American clients. Next. The students I have in the practicum are all third-year students or later, doctoral students in clinical psychology. I've had them from 8 different universities. I've had about 25 students over the last 10 years. Most of themselves are themselves ethnic minorities and or immigrants. I've had them from about 10 different countries and cultures. Many have a second language. I've had 7 Spanish speakers, and since I speak Spanish, we work together. Many have international experience. 7 of the students have been plain vanilla. They've all shown a career dedication to working with ethnically diverse populations. Next. The need, both the training need and the need for the clinical services has been determined by word of mouth. I haven't done a whole lot of advertising or going out there looking for people. They find me, and we've just built from there. The clients that we work with, there are consistent ethnic populations and some rare populations, as you can see below. With the consistent populations, we've been able to build up a database of experience and knowledge and skills, some favorite interpreters, an accumulation of tests and profiles of these populations, and so forth. On the occasional, we've been able to build up skills of how do you deal with a population or an individual from a culture that you haven't encountered before. Next. Here's a listing of the different administrative issues that we have dealt with. The backbone of this practicum is evaluations for medical exclusion from the U.S. English and History Civics exam. If you want to become a U.S. citizen, you have to pass a test in English and a test in U.S. History and Civics. And unless there's a medical reason why you can't learn English or U.S. History and Civics. And so, in a sense, these evaluations are all by definition of non-English speakers and of neuropsychological or potential neuropsychological problems. We typically carry out these evaluations in about 2 hours, and those who are interested in more detail, we can discuss that in Q&A or later. But they give a great opportunity for training because the students get to see a lot of people from a lot of countries with a focused exam. I had the permission of the gentleman on the right here who's Somali, proudly displaying his citizenship certificate. You can see that there are any number of other issues that we address as well: workers' compensation, disability of various sorts, various criminal evaluations, parenting for the state child welfare services, as well as, oh, I don't have it on here, personal injury lawsuits, and so on. Next. We work in the community at a lot of different locations. Sampling of them here, you can see some are community mental health and other services. Some are clinics, various kinds of attorneys' offices, jails, various institutions, and We don't do clinical evaluations in restaurants, but we do some of the practicum there. Because when we're out in the field, we may be spending all day and we have to eat somewhere sometime. And I try to make it a point to take the students to ethnic restaurants where we're talking about the learning experiences, and the restaurant itself becomes another context of learning. And occasionally we actually see people in my office as well. But mostly we're out in the community. Big advantage of that for learning because you have a lot more access to the people you're evaluating. Usually you get more family members there out in the community as informants. You often have easier access to interpreters. You typically have much greater access to the people that you're who have requested the evaluation, and you get to do more direct feedback with them rather than just report feedback. You get to talk with them and hear more, and you get to see much more of the context of where this is being applied and of the life and world of the people that you're working with. So I highly recommend work in the community in this kind of way. Next. The finances. How does one get such a practicum to work on a financial level? Well, the sources of pay run the gamut for me. There's certainly a fair amount of pro bono work here, just because that's what the work sometimes calls for. That's particularly for nonprofits that are offering pro bono services. And as you can see, many other sources of payment. And as is often the case for neuropsychological services, the forensic work often underwrites much of the rest of the work. Next. The format of this practicum is an apprenticeship model. So the students start out observing me in my work, and they gradually take over portions of the work when they're ready. And the advanced students teach beginners. The students themselves, because they are often a diverse group, are cultural and linguistic resources. So we have a very collaborative kind of model. When they know things that are important to know, we call on them for that. When they have access to information, they go out and check it out. And when we have a collection of students together on one day, each case is discussed among all of us so we can share our experiences in that sort of way. At a practical level, because they're coming from 8 different universities, we can't do everything all on one university site. So we have a Google Drive where we have a folder that contains profiles of different populations, test resources, forms, interesting articles, a log of our clients, all kinds of different things. We coordinate our calendar for our different visits in different locations via Google Calendar, and all of the participants can log on in there and write in when they're coming on a particular day to see a particular person. We've got collective development of some specialized tools, and I'll show a sampling of them later on, that have helped us in our work. Also within the practicum, we have a certain number of focused interest groups, which I'll be showing you. And from time to time, we do international consultation, where we may write to or call up neuropsychologists or others in other countries that can help us to understand certain things. Next. Now, I promised a little bit about how to. I'm talking mostly about how to do training, but neuropsychologists participating in these kinds of workshops often want to know the skills how to do evaluations. And I'm going to touch on a bit of that now. And among the skills that the students work on are those listed here. And these are some of our major learning objectives. And I want to point out here for a moment the second item there, interpreter use skills. I've got a link to a video there that's about 8 or 10 minutes long. It comes from UCLA Hospitals. It's one of the best videos I've ever seen that explains the basics of the skills that a professional needs to work with a medical interpreter. I highly recommend it. It does a better job than I could with just words because it illustrates the different techniques and problems and solutions. Taking an ethnic, linguistic, migration, and acculturation history is also a very important skill that we work on. And in the handouts, the separate handouts, there's a suggested semi-structured interview that can be used for that purpose. You can also take a look at the DSM-5 cultural interview. I'd suggest you look at both. The DSM-5 is a great improvement over the 4, but it has its limitations as well. If you want to ask me about that in the Q&A, we can get into that some. Okay, I think that's enough on that. Let's go on to the next one. I wanted to give you just a sampling here, an illustration of what I mean by doing pre-research of the client's background. One of my favorite websites for this is a website called Ethnomed. It's actually right here from the Seattle area, from Harborview Medical Center at Seattle. And you can see here on the home page the different topics and cultures that you can browse and choose from. And they have ethnic profiles of most of the major immigrant groups in the United States from the point of view of medicine and what one would need to know in order to work with those populations medically. Next. And here, chosen at random, is one example of such a profile. You can see here the different topics covered under the contents and how useful that can be when you're working with such a population. 10-15 minutes spent doing this kind of research and reading through really puts you way ahead of the game when working with somebody from a group that you have not been familiar with. It's really critical and important in what you do. Aside from having words about these things, the website also has some photos, a map, and videos that can help you to understand better the population you're looking at. The only things that are missing that a neuropsychologist would want to know in that sense in terms of profile of the population is detailed information about their educational system and legal system. And if you really want linguistic information in more detail, Wikipedia is actually very good at that. And they have good profiles of most of the languages you would want to learn, including a lot of linguistic detailed information, including about the writing system. Next. So the tools that we use in our practicum are ethnicity profiles, such as you just saw, semi-structured interview that I mentioned, which covers not just background, but many other things needed in neuropsychological evaluation. We've specialized the consent forms for these purposes and translated some of them. We have a report template we work with, and I know that we have predominantly North Americans watching this, and you're very, very, very interested in tests. I have to take a slight aside here to mention that we talk a lot about the psychology of cultures, but there's also a culture of psychology. There are cultures of psychology and cultures of neuropsychology. And North American neuropsychologists stand out and are somewhat outliers from neuropsychologists in the rest of the world in our peculiar preoccupation with tests. And there's a joke in medicine that can also apply to neuropsychologists among physicians outside North America. They say that if you go to an emergency room in North America and your leg has been traumatically amputated, no one will believe you until they've gotten an ortho consult and an MRI scan. It's similar to that for neuropsychologists. North American neuropsychologists are particularly preoccupied with tests. And so I'm going to indulge you for a moment and give you a few tests at work here. But really, it's our other clinical skills that are most important in cross-cultural work. It's really our ability to establish rapport, to find out about people's backgrounds, to take a very good interview and observe behavior, and to be able to be flexible and come up with ways of looking at and understanding what's happened with someone. So, among the tools we use, one of the most important ones, especially for the citizenship evals, is a memory test called the Fuld Object Memory Evaluation. Paula Fuld devised this more than 40 years ago. It's available commercially from Stolting, or you can put your own together. And I'm going to show it to you here quite briefly so you can get an idea of what this is. So it goes roughly like this. In this bag, I have 10 common objects. Now I'm going to give you the version that I use for cross-cultural work, and this test was devised for cross-cultural work. But in going through an interpreter, simplified language, simple structures, concrete. In this bag I have 10 common objects. I want you to identify the objects by feeling them. There's nothing in the bag that can hurt you. I'll ask you to put your hand in the bag like this. Find one thing. Feel it. Tell me what you think it is. Then pull it out. So you have the person do that. And so they feel one thing and they say, it's a cup. It's a ball. And they'll go through all the different objects. As you will see here, a bottle, a button, matches, a key, a ring, scissors, a card, a nail. And they've done all 10, and then you say, okay, now I'll put the objects back in the bag. You leave the bag out on the table. Now, I'd like you to tell me all the different animals you can think of as fast as you can for 1 minute while the interpreter writes them down. Now, here's a tip for you. You have the interpreter write them down so you're not having them interpreted while it's being said and slow down the process. Okay, after 1 minute of that verbal interference. Now, I'd like you to tell me what objects are in the bag. So, we've got a memory test here, and if you've had the experience in the past trying to use word lists for memory tests with people with limited education and so forth, you may have run into the experience where they say, what word list? And then they start giving you items from the Boston naming test or from their verbal fluency or from something else. We don't run into that problem with the fold because the bag is on the table. They know what you're referring to. You don't lose track of that. So they tell you as many as they can remember, and then they say, okay, so they say cup, ball, ring, nail. Okay, I know this can be kind of hard. I want you to try to learn what objects are in the bag. I'm going to remind you of the ones that you missed. So this is a selective reminding test, and you say there were scissors and so forth, and you give them the rest. And then you do another 30 seconds of verbal interference. Okay, tell me the objects that were in the bag. 5 trials of selective reminding. There's a delayed recall. And then I've added to the protocol of the fold for our own purposes here. And it's an unnormed and unvalidated, but nevertheless useful procedure, which is a 2-alternative forced choice recognition memory paradigm to check for test validity, for test effort. And it goes like this. I'm going to name 2 objects that were in the bag. I want you to tell me, one of them was, I'm going to name 2 objects, excuse me. I'm going to name 2 objects. One was in the bag and one was not. I want you to tell me which one was in the bag. Was there a stone or a ball in the bag? So we go through all 10 objects in that way with 2 alternative forced choice recognition memory. Can give us some feel for their effort on the test. Okay, that's the fold. Next one that I want to discuss. Scenery picture memory test. This one came out of Japan a few years ago, and very quickly it works like this. I'm going to show you this picture. I'm going to show it to you for 1 minute, and when I'm done, I want you to tell me everything that you can remember from the picture. So you've got a little bit of verbal interference, and then you have them do their memory, and then you come back and you have them name the objects in the picture, and then you take it away again with a little more verbal interference, and then you have them have a second recall of the objects in the picture. So that's another alternative. Another test that we use, the San Diego odor identification test. This was a test that was devised for odor identification testing in primary care. It's a quick and easy test, and it's often important in diagnosis of dementia or for the anosmia or decreased odor identification abilities that can result from a lesion from a severe traumatic brain injury that shears the first cranial nerve. So you can make this up in your kitchen. Look it up, the San Diego odor identification test on the web. And so you have little odorants that you have in little containers, and you say, okay, close your eyes. I'm going to put this under your nose. I want you to smell it and tell me what you think it is. You can do it by direct identification, and you can also do by multiple choice. I've got the names written out in a whole lot of different languages because I've got my interpreters to do it. That's San Diego odor identification test. Coin rotation test. Very nice little test of motor dexterity. You're trying to use something like finger tapping or groove pegboard. Sometimes there are people with limited education who don't quite understand the task, but this one, everybody gets it. You use a quarter. How many times can you turn it over and over again in your fingers in 10 seconds? And then you do the other hand. There's some norms for this, but even without norms, you can compare one side of the body to the other, and you can compare the person to themselves to see if there's change over time. I want to mention quickly the bilingual aphasia test. This is available for free online in 57 different languages and over 100 different language pairs. And it's a very good translation job done. All the stimulus materials are here for all modalities of language. Like most aphasia exams, it's a low ceiling test. It's a clinical science test. Doesn't need norms that much, but if you're interested in looking at language functioning, it's available in a whole lot of different languages. And if you need materials for sampling reading and writing abilities, you've got it there. I also want to mention quickly the 5-digit test. Manolo Sado, a school psychologist, neuropsychologist from Boston, has put this together. And it's available from Tella Ediciones from Spain. Hopefully we'll have an English version of it sometime soon. It's devised specifically for people who have low or no literacy. And it's an analog to the Stroop test. And it works as follows. Okay, on this page, here's the sample. I want you to read one number in each box. And most people, even illiterates, recognize at least the first 5 digits. And then you've got a whole page here in which they do that as fast as they can. Second page. Tell me how many stars, how many asterisks are in each box, 1 through 5. Whole page of that. Third condition, here's the Stroop condition. You've got digits in the boxes, but you say how many digits are in each box, rather than reading the digits. So that's your Stroop effect. Full page for that. Fourth condition, same thing, but as with the DCEF's color word. Do the same thing, tell me how many digits are in each box, unless the box has a thick border around it like that. And in that case, you read the number instead of telling me how many there are. So this has got that multitasking, that flexibility of thinking to it. And a full page of that. Okay. Next slide, please. Okay. Now, I mentioned that we've come up with certain tools for ourselves, and this is a procedure. We can't really call it a test because we don't have norms on it, but anybody looking for a research project is more than welcome to help us with this. Because what we found in looking at people's ability to learn English was there were some people who did very well at the full object memory evaluation, and yet they'd spent 2 years at level 1 in their English as a second language class, and we knew something else was going on. Some of these turned out to have a learning disability, a language learning disability. Some people who had had a left hemisphere stroke with aphasia and had recovered from aphasia, but their language learning just wasn't working. So we went to the literature and looked at what are the cognitive abilities that are involved in learning a second language. Not a huge amount of literature on that, as it turns out, and no really good tests out there, so we had to make our own. And here's the procedure we did, and it gives us a lot of insight as an informal procedure. So we go like this. I'm going to show you some people here, and I want you to learn their names. I hope this is working well. So this is Relst. This is Eltai. This is Garthan, and this is Ardula. Now we're going all the way back to Ebbinghaus here with learning nonsense syllables. These are basically all in English phonology, but nonsense syllables, and it has that ecological validity of names are kind of weird, and learning somebody's name is a common kind of thing to do. So first we do recognition. Which one is Eltai, which one's Relst, which one's Garthan, which one's Ardula. When they can do that for us with it written, Now, if they know English alphabet, great. That's the tool they have for learning English. If they don't know the English alphabet, that's what they've got. Then we turn to this. Which one's Altai, which one's Garthan, which one's Relst, which is Ardula. Okay. Next procedure, we do that until they learn it. Train to criterion. Say Relst. Say Altai. So we do repetition. Okay, who's this? Who's this? Who's this? Who's this? Okay, say Garthan. Who's this? Who's this? Who's this? Say Ardula. And we have them learn them all. And then, okay. Who's this? Who's this? Who's this? Who's this? So basically, we're doing what would be typical language training for learning new words. And we're doing it with faces in that sort of way. And then we do a delay of a few minutes. And then we put them out again. And we do delayed recall. Who's this? Who's this? Who's this? Who's this? And then we've got a tiny little bit of a test effort probe here. Is this Sarah or Ardula? Is this Joe or Garthan? Is this Altai or Jane? Is this Relst or Fred? Okay. The one last thing I'll show is that in the citizenship test, the nature of the citizenship literacy test is very described in great detail on the website. And so we have taken that to devise a reading and writing test that uses the same words that are used in that literacy test. And so we can check how far along someone is in learning their literacy. Can they read the sentences? Can they read the words? Can they read the letters? Can they read numbers? So we've got that for doing a quick probe for that test. Again, we're going with what's really practical, what's really relevant to what we need to be evaluating. Next. We have several different groups, as you can see here, among the students who focus on particular interests as per their background. Next. And the future of the practicum. I personally am very interested in training people who want to do this kind of training, and in a sense franchising, not in a financial sense, but just in the sense of distributing this model to other folks who are interested in that. And I'll be very interested in hearing from you if your program is interested in developing something similar. Next. Okay. I'd like to talk now about what some neuropsychological cultural competencies are. Next. Many psychology programs these days, most of them, have courses in cultural competence and diversity competence. And I have a listing here of what are generally regarded as important cross-cultural clinical psychology competencies. And these, of course, are very important for neuropsychology as well. Next. And we'll presume that our neuropsych students have already gotten this kind of background. But beyond that, there are some cross-cultural competencies that are more specific to neuropsychology. Next. These include learning about international epidemiology, learning about some of the things we already mentioned regarding linguistic and cognitive diversity, educational systems, and illiteracy. Next. It also involves particular neuropsychological interview and intervention skills. Next. And, of course, testing skills. Very important is knowing about test translation and adaptation principles. There are great principles out there. They've been out there since about 2002 from the International Test Commission guidelines, available free online. Not as well known in neuropsychology as they need to be. There's also a lot having to do with how do you test people who are test naive. And that's a whole skill set that we work on directly in the practicum. Also, along with that, is understanding what are the background assumptions of assessment and their variance and why they are not cultural universals. One of the best sources I know for this, next, is in an article by Alfredo Ardila from 2005, and you can see here listed out a number of the background assumptions of testing that are not cultural universals, and understanding how these can vary and how to deal with them when they vary is very important to being able to do cross-cultural evaluation. Next. Beyond that, we can consider distinctive objectives for such learning depending upon the background of the student and the cultural and linguistic background of the student and of the instructor. So if the student is monolingual and monocultural and not likely to learn another language, they're going to have learning objectives of learning good interpreter use skills and cross-cultural communication. Next. There are quite a few students who are bicultural, but they don't have the language skills that would allow them to work with folks of a different culture. They understand the culture, they've got that kind of ability to establish rapport, but they'll need interpreter use skills. Next. Now we're going to talk about L1. In this context, we're going to say language 1 is English in a North American context. That is the language in which neuropsychology is being carried out, who the professionals are, what you're writing your report in, etc. And L2 would be the second language. For ease of speaking for North America, we'll talk about Spanish, though we could also be talking about Vietnamese or German or Chinese, whatever. So a bilingual, bicultural student who is stronger in English, maybe they came to the U.S. at a young age, maybe they learned Spanish as a second language, their learning objectives could also include developing clinical and academic proficiency in L2 in Spanish, say, and being able to access professional literature in L2. Another option might be to also develop skills as an interpreter themselves. Next. And the bilingual, bicultural student who is L2 dominant will probably be wanting to develop academic proficiency in both languages and clinical proficiency in both languages, accessing the professional literature in their home language. They may also need and have part of their objectives learning acculturation to U.S. academia and U.S. medical settings. And April has proposed that we might have to have a whole webinar on that, and I think it's a great topic. They may also be wanting to learn interpreter skills as well as translator skills. Next. Now, there are also some variants in training in terms of the training modalities for different students depending on who their supervisor is. If you've got a monolingual student and supervisor, it's still possible to do very good training in cross-cultural work. You just need to have a cultural consultant working with you and work on good interpreter use skills. And a tip from Adriana Strutt, a neuropsychologist who's bilingual, bicultural, who's done this kind of supervision, is when you're doing that supervision, the cultural consultant has to talk with both the supervisor and the student at the same time, or it's not going to work. When the supervisor has more cultural competence, you may make less use of the cultural consultants. If you've got a bilingual supervisor, the student will be working with the interpreter and cultural consultants, but not necessarily the supervisor. Next. Then when you've got the bicultural student, we can see that we've got some slight adjustments in training modalities here. And next, when we've got the bicultural, next slide please, when we've got the bilingual student and the monolingual supervisor, I've had lots of fun with this the last couple of years. I've got a student who speaks Russian and a student who speaks Punjabi and Hindi. I don't speak either of those languages, but we've worked out how I can supervise them working in their own language, and we've also trained them to be interpreters, so they can be my interpreter while I'm doing clinical work, while they're doing clinical work, and we get very clear about when we're switching hats. In the handout material, there's a whole lot about that and working at different levels of bilingualism for both the student and the supervisor. Then last, I want to point out that if both the student and the supervisor are bilingual in the same language, in addition to these other modalities of working, I strongly recommend doing at least some of the supervision directly in L2. Because when you're talking about the clients and the cases in that language, it subtly shifts the way you think about it, and it helps you to develop that kind of clinical and professional vocabulary. Next. Now, here's something that's a little bit of a touchy subject, but I really want to get to it. A neuropsychologist or a student who is bilingual and bicultural nevertheless needs certain professional training in order to be neuropsychologically culturally competent. That has to do with learning the principles of language and culture, test translation and adaptation, the epidemiology, and so forth, and doing that in a professional context with mentoring from others and so on. And we need to be open about this and address this and do it clearly. I've gotten a lot of students coming to me complaining that their supervisors expect them to be culturally competent when they feel that they need better supervision in how to do this. They need this kind of training and they're not getting it. Next. So just 2 slides left and 15 seconds left. Go. Next. And this is kind of a summary here. My recommendations in terms of training: base it in the community if you can. Go where the immigrants are, where they congregate. Get to know their context. It will help. Network, network, network. Get to know your community, the ethnic communities in your city, in your town. Get to know the neuropsychologists who work with those nationally and internationally. Get to know the other professionals who work with those groups, and use a collaborative learning model. Next. That collaborative learning means using the background of your students and their cultural expertise and linguistic expertise, but not abusing it, not expecting them to have expertise that they don't have. Make sure you give them the supervision that they do need to be able to do a competent job. Tap into the international literature. There's nothing I hate more than to see a report saying, well, there are no tests available for this person, which really means I didn't look much of the time, when there are lots and lots of tests available. Sometimes that means going to literature in that language to find them. Or you might say, I don't have the tests, or I couldn't find them, but don't say they're not available when they are. We might consider in the future getting more generous with having international rotations and providing that students can go to other countries to spend 6 weeks, a couple of months working in another language and developing skills there. And in setting up such programs, concept of triage, finding those clients that we can most easily make the biggest difference for. And being out of time, I'm going to end it right there and pass things on to Melissa and look for your questions and answers and so forth. Thank you.
Thanks, Dr. Judd, for your excellent presentation. Next, we're very glad to have Dr. Melissa Castro on this webinar. Dr. Castro is First Nations Native American. She was born in Mexico and raised in Canada. She speaks Spanish, French, and English. She completed her PsyD at the Ponce Health Sciences University in Puerto Rico and her internship at the University of Manitoba in Canada. She did her postdoctoral fellowship at the Mayo Clinic in Rochester, where she also worked on foreign language services with individuals from around the world. She is currently a clinical neuropsychologist in the Department of Neurology at the Dean Clinic in Madison, Wisconsin. She offers bilingual services and cross-culturally neuropsychological assessments in both English and Spanish. Her research interests include cognitive rehabilitation for mild cognitive impairment and early dementia. She's an advocate for improving culturally competent practices in neuropsychology. We'd like to welcome Dr. Castro.
Hello, good night. Thank you all for tuning in. It's an honor to be presenting with Dr. Judd tonight, whose talk is just stupendous, very interesting. Tonight, I'm going to be giving you the talk that I always wish for as a trainee, the talk on how to put all that theory into practice so that the next time that you have a non-English speaking patient, you don't just feel like you're winging your way through it. So as you can tell by the title of my talk, the majority of cross-cultural assessments that I do are in Spanish, but I believe that many of the points that I'm going to discuss tonight can be applied to other cultural or linguistic groups as well. I've worked predominantly in medical and academic institutions that differ very much from private practice. They involve their very own set of hoops to jump through, which we'll talk about tonight. But I think regardless of where you're practicing, I hope that covering some of the basic groundwork will help you in setting up your clinic, offer cross-cultural neuropsychology services, and by breaking that process into 10 steps, you'll have the basic tools so that you can feel more prepared and confident to take on that task without having what we call un ataque de nervios, or a panic attack. Next slide. Sorry guys, it looks like I just muted my microphone. I hope you guys can hear me now. Okay, so I want to start off by telling you that if you feel unprepared when it comes to these types of assessments, you're not alone. In the field of neuropsychology, less than 10% of neuropsychologists identify as ethnic minorities, and only about 3% are Hispanics, which is pretty small considering that Hispanics are the largest minority group in the US, making up 17% of the population, according to recent census numbers. So in the next 50 years, we expect that number to grow by about 30%. And it's pretty concerning then that the majority of neuropsychologists feel entirely unprepared to work with this group of Hispanics, regardless of what language they speak in. In fact, only 1% of neuropsychologists actually feel really well prepared to work with Hispanics. So our aim tonight is to make that 1% grow. And considering that there's over 300 of you guys here tonight listening, and if you think that there's only about 1,000 board-certified neuropsychologists practicing right now in the US and Canada, I think we have a pretty good chance of increasing that number for the next generation of board-certified neuropsychologists. So it is a fact that the more confident you feel working with these patients, the more patients you will serve. Next slide, please. I also want to take away some of that fear or intimidation that comes from doing these type of assessments. I think that trainees are usually really eager to take on these kind of cases, but when they're confronted with the complexities surrounding these types of assessments, they're often warned, as I was, no good deed goes unpunished. And I can't tell you just how many times I've heard these words. They've become somewhat of a consolation prize to make me feel better about how many times my good intentions were often misunderstood or unrecognized. In fact, I think I heard this mantra so often that for a while I even started to believe it. And every time I saw a foreign name on my patient roster, it evoked a feeling of ambivalence in me. Indeed, I was curious about it, but I just had this knowledge that inside of me that this evaluation was going to be much more effortful in every sense of the word. So now you ask me, why do I keep doing these type of assessments? And it's because once that name becomes a live person in the flesh, that ambivalence completely evaporates. Working with these patients is incredibly rewarding. An immense satisfaction of providing them with a service that makes them feel listened to, makes them feel understood and cared for, a service that so few can provide. Next step. That's why the step number 1 is to help you build your support system. You're definitely going to need it. As a bright-eyed student, I always assumed that my supervisors knew best, and I came to realize that this wasn't always the case, as in many situations they felt just as unprepared as I did, if not more so, because they also had to deal with some of the language barriers. So for this reason, you're going to need to seek out neuropsychology mentors who have experience doing these type of assessments. I encourage you to join EMA and ANST as they're dedicated to fostering these type of connections. Joining HNS is also a must on that listserv. There are many mentors on demand. In fact, you can even go online and find Hispanic neuropsychologists that are in your state or region. You can find me under Wisconsin. The listservs that are, the links are listed on this page, are free for APA members, and the HNS membership is very affordable, only $30 for students, $50 for professionals. The International Neuropsychology Society, or INS, also has a cross-cultural database for folks all around the world who do assessments in many languages. And it's been my experience that these folks for this type of work are incredibly receptive and enthusiastic about helping others. So don't be shy as I was. Post on those listservs, get your name out there, and you'll have lots of support. Next slide, please. So now that you have the strength of an entire nation of neuropsychologists at your fingertips, you can move to step 2, making a business plan or a training contract. Whether you're a trainee or a licensed professional, this is a really wise step to do. My experience has been that most departments and institutions will applaud your willingness or desire to take on the task of providing services to Hispanics. They recognize that there's an unfulfilled need, but they often don't know what it takes to meet that need. They'll be all gung-ho, they'll encourage you, but few understand that doing this type of work is much more than simply doing what we usually do just in Spanish. It's entirely its own specialty. So when making a case for buying more Spanish test materials or increasing hiring efforts to hire Spanish-speaking support staff, it's going to help to have some data to back up your requests. So when they ask you, why can't you just translate these test materials yourself? Why can't you just use an interpreter? Why do you need so much time to do these assessments? There's answers to all of these questions, but before you even get to those, it's going to help to have some basic information about basic supply, basic demand, because your institution is going to want to know that they're making a good investment. And as we've already discussed, supply in terms of neuropsychologists offering these type of services is very low. Demand is high, but most folks don't realize. Next slide. Institutions understand numbers, so you must speak to them in numbers. From their perspective, they've been seeing a certain X number of Hispanic patients, so they assume that that represents the demand in their community. So for reasons Dr. Judd covered in his talk, we know that this likely only represents the tip of the iceberg of true untapped demand. For example, in 1997, the average amount of Hispanic evaluations in neuropsychologists did per year was about 15, just over 1 a month. But the range you can see is pretty incredible, from 0 all the way up to 480. And naturally, this is going to vary depending on where you live, but you're still going to want to get a sense of how many Hispanics are being referred for neuropsych assessments at your institution, but most people don't know how to get those numbers. In my experience, the best way to track those stats down is to go through your Office of Interpreter Services, as they have the documentation on how many times your department ordered an interpreter and for what language. If you get more demographic data on your referrals, I'd recommend including Hispanics that are also English speakers or bilinguals, because they often still need Spanish testing. And once you have that number, don't be disappointed how low it is. Understand that it is an underestimation of true current need as well as future need, because we do know that the demand is growing. In 2012, the percentage of Hispanics who lacked health insurance was 29%. Now with Obamacare, it's a whole new world. Right there you have a 30% increase in potential demand. Now consider that the Hispanic population is growing rapidly, the elderly population is growing rapidly, boom, you even have greater demand. Next slide. In fact, over the next 50 years, as you can see by this chart, Hispanics are going to make up almost 20% of the population over the age of 65. And if you accept Medicare, you better be ready for it. Next slide. Now let's take a look at geographical layout. I recommend getting a layout of your land. If you are in the United States, you can see here in the purple or dark blue states represent how many people are from Latin America and the Caribbean. And those blue and dark purple represent states where over 50%, they make up over 50% of the foreign-born population. The chart on the side shows that about 4 states account for 63% of foreign-born individuals from Latin America and the Caribbean. Those 4 states are California, Texas, Florida, and New York. So in those states, minorities are much more visible. And they'll likely have better access to services in Spanish. Next slide. Here you can find out how many Hispanics are in your state. I know it's pretty small, but if you blow this up, you can find your state listed here. So for example, in my state of Wisconsin, there are 110,000 Latinos. About 80% are from Mexico. Another 8% is from Central America, and 8% from South America, and only about 4% are from the Caribbean. I would say that this is a pretty decent estimate of the breakdown of patients I see in my clinic, except for Puerto Ricans, since they wouldn't fit into this category as they're not considered foreign-born. They're considered native-born since Puerto Rico is a U.S. territory. So generally, if you just want to look in some broad numbers in the U.S. population at large, Mexicans rank the largest group at about 64%, and then Puerto Ricans would be the next largest at almost 10%, followed by Central Americans and Caribbeans. Next slide. Now, numbers and percentages are so abstract, so I really like to show people a series of slides that documents the growth of the Hispanic population over time. The dark indigo color represents more Hispanics relative to the percentage of the total population. So as you can see here in 1980, the Southwest is highly populated with small pockets in Florida, New York, and Chicago. And with each decade, that blue becomes more and more prominent. So if you go to 1990, 2000, that by 2006, I think they decided to change the color scheme because it became a little too intimidating for some folks to swallow. In 2010, the colors were muted with dark purple representing the counties where Hispanics made up more than 50% of the population. They also, for some reason, finally chose to include Puerto Rico, which had not been included previously. So if you are in one of the white states, I don't think that you're in the wrong region for offering Spanish services. I want you to know that's definitely not the case. Next slide. This additional analysis here I found pretty impressive. It includes a map of how much the Hispanic population has increased in each county from 2000 to 2010. Here in dark blue are the counties in which the Hispanic population has increased by more than 100%. That means that at least 1 in every 4 counties, the Hispanic population has increased by more than twice their size. Those greatest increases are occurring precisely in those white states. So no matter where you live, there's definitely a growing market for Hispanic services. And with these numbers in hand, you should be able to more than make the case to get others to invest in your efforts to improve services for Hispanics. So let's move to step 3. Next slide. Gathering your materials. I've listed here some official resources which I found useful to support and justify my arguments when I'm asked to do things like use family members as interpreters or use interpreters as psychometrists, or even do things like translate on site. Things which any good trainee or any good neuropsychologist who's ethical will avoid doing, and if you're unsure why you shouldn't be doing this, I suggest reading each and every one of these papers before proceeding with any of the next steps. But let's move along. A really good resource to have is a good reference library. Here's a list of textbooks that you can add. A lot of them are very helpful, not just for Hispanics, but many different types of cross-cultural assessments. Next step, now that you have all your books, time to collect your tests and norms library. For a comprehensive list of every test and every inventory or questionnaire that's ever been made in Spanish, just go to the HNS website. If you're a member, you can access the database, and you'll see that there's 175 measures there. And I'll talk a little bit later about some of the most commonly used tests that I use and others use, but let's talk a little bit more about norms. Some tests come with norms, whereas others do not, and some you're going to find the need to find different norms depending on what country your patient is from, whether they're monolingual, whether they're bilingual. Each data set has pros and cons. What I did was I literally just photocopied each table of Spanish norms, every single Spanish norm data set that I ever came across, and I put them in a big binder. So I have a pretty nice collection now. I've been collecting this for years. The handbook has several and comes with descriptions of the advantages and disadvantages behind using each normative data set. Literally, I just photocopied each table and then organized the norms by test. So say if I gave the trails color version or regular version, I could just look up that section and see all the different norms available for that test. The compendium has some tests, but not as many. I would recommend going to the index section, where you can find in the section under Spanish tests and French tests a list of all the page numbers that have those, and you won't have to do like myself going through the entire book page looking for them. The next reference that I have here for you is the NeuroNorma data set. Now, there's many norms available online through different journal articles, but some of them are difficult to access, especially if you don't have journal subscriptions. The reason why I like the NeuroNorma is because it's a very large data set. It's published in Spain, and it's available through the archives for free. So literally, all you have to go to that link, and you can download all of these norms. They used to only have norms for older adults, but now, as of last year, they've just expanded the data set to younger adults as well. Next page. Now, I'm very excited about this new normative data set that's coming out. Dr. Zarengo and Perin, they unveiled this very, very ambitious project at NAN this year. They were giving a talk on culturally sensitive neuropsych evals, and they presented this sample of over 5,000 individuals from 12 different Latin American countries. And the tests that they use, their tests we're all familiar with. There's even an effort measure. It only takes 70 minutes. It's got a broad age range. I'm really excited about seeing these norms when they come out. They said they should be coming out in the next year or so. They're going to make them, researchers are also planning on making these norms readily accessible to all. So keep an eye out for these. Next. So now that you've gathered all of your materials, it's time to set up your actual clinic. This is hopefully going to involve setting up some support staff, most importantly, a bilingual psychometrist. I'd recommend recruiting from your local university languages department if they have one. We've had very good luck finding very good candidates from the language department. I prefer those that major in Spanish and psychology. These students have experiences studying abroad. They've done immersion programs. Unfortunately, I've tried to recruit from the general community sources, but I just haven't had that much luck. I've also advertised on the National Association of Psychometrists website, which is linked there. LinkedIn, Facebook, social media, I just haven't had as much luck with those avenues as going straight to the university. If you are lucky enough to be a bilingual psychometrist and bilingual staff, you're going to want to assess their level of proficiency, perhaps documenting it in each language, both English and Spanish. I usually test their language skills informally in casual conversation and the interview, but you may want to have them do testing or a more formal evaluation before they start testing with patients. And I'll talk about that in a little bit as well. Just understand training is a big investment, and I find it easier to train someone in Spanish when they already have a solid foundation on English testing skills already developed, as opposed to trying to teach them both English and Spanish testing skills at the same time. Let's talk about setting. If you have one clinic, you're going to want to store all your materials in one spot. I have 2 clinics, and I used to transport my materials from site to site, but things started getting misplaced and lost, so I've decided only to do my Spanish testing in one clinic, just to simplify matters for myself. Next slide. Try and make that dedicated space that you have welcoming for minorities. Put Spanish brochures, reading materials, put posters up in the waiting room that have pictures of diverse people. In my office, I try and display my Spanish certificates and diplomas prominently. And I was lucky I had the opportunity to plan the layout of my office. So I tried to make it so I could comfortably accommodate several people. Because in these cases, you may have the patient, various family members, including kids, interpreters, case managers for workmen's comp cases. You could have quite a few people in your office at once. But speaking of workmen's comp, let's talk a little bit more about referral sources. Next slide. So first you should give some thought as to what kind of referrals you're ready and willing to see. I work in a medical institution, so I must prioritize my patients who are seeing me for medical care. I've also worked in departments whose policy actually excluded cases, anything that was legal in nature, and that included citizenship evaluations. These cases were often referred out to private practice. I personally don't see these evaluations because these cases would overwhelm my pretty large caseload. This month, I've seen about 6 Hispanics, 1 deaf individual, 1 Indian person, 1 Native American person, and a couple of African American patients as well. So, you know, I think I see a lot of cross-cultural patients on top of my regular caseload. I've always found that word of mouth has worked pretty good for me, but if you want to increase your referrals, I recommend working with your institution's marketing department, getting advertisements or ads in the local community newspapers, get advertisements in centers for minority groups. If there are other neuropsychologists in your department, you're probably going to want to discuss with them and your schedulers about how all of these foreign language patients are going to be distributed amongst the different providers. As the only Spanish speaker assessing adults in my institution, we've pretty much agreed that all Hispanic patients will be routed through to me to ensure that all patients are getting pretty much the same standard of care. And if one of my colleagues does see a Spanish speaker, I always make an effort to consult with them or even do some of the testing for them. So after medical diagnostic referrals, I do get a lot of academic referrals as well as disability and workman's comp cases. I make a point to ask patients up front at the very beginning of the consult whether there are any legal or citizenship cases currently underway. Because it's been my experience that if you don't ask them, they won't tell you until the very last minute at the end of the feedback session, when they say, oh, by the way, can you fill out these forms for me? So I've since learned my lesson, and I'm very upfront about letting my patients know what kind of assessments I do, and that in these types of cases, I cannot always guarantee that my evaluation will support their case or their application. Next slide. Now, Ted has already spoken quite a bit about the citizenship and naturalization process. I don't want to speak too much about it, but I do want to cover it briefly, just because there are a couple of language exemptions that I think are important to know about. So the citizenship and naturalization process includes 2 parts, the English test and the civics test. The English test, you have to answer some questions assessing your reading and writing abilities, as your ability to speak English. You can get exemption from the language requirements of those tests, but in order to qualify, you have to meet certain requirements known as the 50-20 or 55-15 exemptions. These refer to your age and the amount of time you've been in the U.S. as a permanent resident. So that's important. If you've been in the U.S. for longer and don't have permanent residency status, it does not qualify. If you meet those requirements, that means that you can take the examination in your native language, but you must bring a qualified interpreter with you, and you only have 2 chances to pass this examination. So if you fail, your application is denied. And it's perhaps for this reason that people are more interested in obtaining medical exemption. Medical exemption, or exemption for a medical disability, means that you don't have to take either of those tests. But in order to qualify, it must be medically determined that you can't do the exam because of a physical or developmental disability or a medical impairment, even when provided with reasonable accommodations. That would include things like interpreters, extended time, off-site testing if needed. You know, the only people that can provide these exemptions are medical doctors, osteopaths, as well as clinical psychologists. So it's pretty ironic that the very people who provide these exemptions are themselves providers who need interpreters to communicate with these patients themselves. So I want to talk a little bit more at this point about the art of interpreting. Now, knowing another language is not enough to qualify you to be an interpreter. I speak 3 languages, and I realize it's incredibly difficult to be an interpreter, let alone a medical interpreter. Sorry, next slide. I don't think I could ever do it. Many institutions require that a certified medical interpreter be present for every patient. Being a neuropsychologist, you're also going to want to ensure that your interpreters have mental health certification, given the pretty delicate nature of our work, if you're planning to see patients without an interpreter, be prepared to provide proof of your language proficiency and possibly be tested on your own language abilities. So usually interpreter services is the department that's involved in this whole process. They're also a great resource if you need translation of clinical documentation, consent forms. I usually have my psychometrists, if they are Spanish speaking, translate any protocols or testing materials if necessary, as they usually have a better concept of what it is exactly that I need. With patients and trainees, it's also important to address potential differences in accent and vocabulary. Even though we all speak Spanish, there are so many regional variations. I may struggle to understand one particular group more than another, and vice versa. So don't be shy to ask them to explain what they mean, even when you don't understand a term or perhaps an expression. I have to say that this is a pretty common experience no matter how good your Spanish is. So with that said, let's move on to the interview. Next slide. So I've noticed that many English-speaking providers tend to spend less time with non-English-speaking patients because of language barriers. Now, that is not the case for me. My consults are typically much longer with Spanish folks. I typically spend anywhere from 60 to 90 minutes for an initial interview. And the reason for that is because once that patient realizes that they have the opportunity to be heard in their own language, then the floodgates open and you hear more than you could have ever imagined or ever wanted to hear. I like to have my tests scheduled on a separate day, so that gives me some time to prepare. It's often hard for me to get everything scored up on the same day, as I'm also seeing English patients in between. So as a result, I often also have to do feedback on a separate day. So factoring in scheduling issues, no-shows, this can make for a very prolonged assessment. It recently happened that I had the good fortune of having 3 Spanish patients scheduled on one day, and so I was so pleased because I didn't have to switch languages constantly. And then I was like, this is great. I want to do more of this. So I came up with the idea of reserving a separate day every month just for Spanish assessments. And my plan was to set up this specialty clinic for Spanish speakers. Now, people likely won't bat an eye if you want to set up a memory clinic or an epilepsy clinic where patients can get specialized services, but I do warn you that if it involves ethnic minorities, it could be perceived by some as discriminatory. So you may need to consult with your legal department beforehand to make sure that you have all your bases covered. Now, when scheduling your specialty service, keep in mind that the consults, as well as all other aspects of the evaluation, typically take longer. At this point in time, I don't have any Spanish-speaking assistants or trainees, so I often find myself doing everything, even much of the scheduling. I often find it easier just to do it myself than to try to communicate to administrative staff or get language lines involved to contact my patients. So it is a huge time investment. Next slide. Many ask, geez, why does it take so long? Not only do you have to spend more time establishing trust and rapport with Hispanic patients, like I said, once those floodgates open, they'll tell you even more than you wanted to know. People often tell you about negative experiences that they've had with the medical system. Many have had very little experience with doctors, and they just simply lack the understanding of the medical process. They already distrust the medical establishment, and they may be especially suspicious of psychologists. So they're usually pretty apprehensive about this whole process before they even step in my office. And many may consider IQ testing just to be disrespectful. So I find it helpful to take the time to address their concerns and empathize with them, letting them know that I care what they have to say and that I'm here to help. Now, there's often more self-disclosure involved because patients often ask where I'm from, so I discuss a little bit of my background, and we try and find some common ground. Now, this is very common amongst Hispanics, and it even has a term, it has a name. It's called personalismo, or a desire to find something in common with each other. As Echemendia, one of our neuropsychology colleagues, so elegantly put, it's many Latinos have a distaste for the impersonal. So this whole issue of personalismo, of course, takes time, and taking your time is something that's highly valued because good things take time. To give one's best is not to do things quickly, which you'll also learn when you're testing minority groups. I recently had a patient who took over 1 minute to respond to every question, and I know this precisely because I actually timed it. So that was a very, very long assessment. But I like to say, you know, as the famous song goes, que será, será. And I'd like to add to that, cuando será y solo si Dios quiere. In other words, in English, what will be when it is to be, and only if God so wishes. And I make special note of this because it results in patients sometimes being late or no-showing with little to no regret or feelings that they're disrespecting you or any feeling that they're doing anything bad. So I encourage you, don't be insulted. You know, try and empathize with this patient the best as you can. I often apologize for any bad experiences they may have had in the past, and I tell them that I'm going to try and do my best to make sure that doesn't happen with me. So how do you know that you've established sufficient rapport? Next slide. You'll know when you stop having those panic attacks or ataques de nervios about doing Hispanic assessments, and you start having Hispanic attacks. What is a Hispanic attack? Well, let me give you an example of what a Hispanic attack is, or what it can feel like to be a Mexican treated in a U.S. medical institution. So just a couple weeks ago, I had a patient from Mexico who had never in his entire life been to the doctor. He'd been living in the U.S. for many years with his wife. She was American. He spoke no English, but he loved gardening. He was an extremely hard worker. He'd been working for the same company for almost 20 years, and he even had the reputation of being la bestia because he was such a hard worker, the work beast. So this all was up until the day he suffered a head injury at work. And because he was receiving workman's comp benefits, he had been poked and prodded for months before he finally made his way to my office. And he confided to me how happy he was that finally he could speak to someone without needing an interpreter. He and his wife then told me how embarrassed they were that they had to talk about their medical problems in front of strangers. He and his wife had such an awful experience with their interpreter and with their case manager that they told me that they wanted to give up on the whole medical process altogether and just not get medical treatment anymore. He started having panic attacks every time he went to the doctors. And, you know, he's not alone. I've had other, you know, non-Spanish speaking patients who've had similar experiences. Also this month, I had a deaf individual who was just unable, absolutely unable to establish rapport with her interpreter. And I have to say that when the rapport with the patient and the interpreter have deteriorated to that point, the patient may very well be justified in declining interpreter services. Next slide. On that point, I want to talk to you a little bit more about informed consent. So if the patient does turn down interpreter services, make sure that it's not because they think they have to pay for the service. They often may think that it's something that's going to come out of their pocket, and so I really communicate that it is a free service that they have the right to. And make sure they also understand the neuropsychological process. We send out consent forms. They're translated in Spanish, but patients still have a really hard time understanding them because of low literacy levels. And again, you know, just a general lack of familiarity with the whole process. Now, if you are video or audio recording the evaluation in any way, make sure to get consent forms as required by your institution. I do audio record some of my verbal memory tests because even with a slow patient, like that patient who I told you took a minute to respond to every item, for some reason when it comes to verbal memory of stories, all of a sudden they're speaking a mile a minute, and the audio recording just helps me ensure that I don't miss anything. So it gives me that extra confidence that I'll get the whole spiel, the whole story. Let's talk a little bit more about testing now. So step 8, finally, the big day. Notice that this is step 8. So much more preparation comes into play before we actually get down to doing testing with patients. Next page. The language that you test in is going to be determined by the patient's language skills as well as the purpose of the evaluation. Now, of the 6 Spanish patients I have this month, 3 of them I tested in Spanish only, 2 in English only, and 2 in both languages. Now, as a rule of thumb, it's often preferable to test in the language that the person completed high school in, because this is often their dominant language. For monolingual patients, you're obviously going to want to test in the language, in their dominant language, even if you want to determine whether they have sufficient language skills to learn English, as Dr. Judd spoke to us about in his talk. So assuming that the dominant language is Spanish, then you're going to test Spanish if the evaluation is for medical or diagnostic purposes. Even if the person is bilingual, it might be preferable to test personality and emotional functioning in Spanish as well, because they may feel that they can express their emotions better in Spanish than in English. I know some will say, I think in English, but I feel in Spanish. And let's see, you're probably going to want to test in English for academic or work-related evaluations, or even if you want to determine whether a patient can benefit from treatment or cognitive rehab offered in English. It's also important, of course, to determine competency in legal matters. Now, my personal favorite are assessments for bilinguals because it means I get the opportunity to test in both languages. And it'll be especially important to do so to determine which language they're most proficient in, as well as when evaluating for language disorders, which is often very important in epilepsy cases. Next slide. I used to the flexible approach to choosing my norms, where I would tailor my assessments to the best normative data set I had available for each patient. Well, that turned out to be incredibly tedious, and it meant everything usually had to be calculated by hand and then compiled together in like this Frankenstein-like fashion. So I now value the fixed approach a lot more, and this is where I try to use one main normative data set. And I have to say that what I lose for in specificity, I make up for in consistency, because I know the quality of norms across all the tests are equivalent or consistent. And if it does happen that I have to choose between norms, I often place a higher value on education-corrected norms, as well as SES status. Education is probably, education and SES are probably the biggest predictors of neuropsych performance. And so if you had to choose education norms over age norms, I'd always go with the education. Next slide. And I want to take the opportunity to make a quick note here about the pros and cons to use computerized tests. Now, I highly encourage using technology to make our evaluations more efficient, but if you're to use common computerized tests such as the Wisconsin Card Score or the CPT, I would advise doing so cautiously. And you know, I think it's great that we can adjust tests to be administered in different languages and have them scored immediately, but many of my patients can barely read, let alone use a computer. And the concept of a mouse is entirely foreign, and although it's easier to use if you know how to use it, I've often found that if a person is computer illiterate, they'll choose to use the keyboard instead. And that's because they're more familiar with how to push a button than how to use that funny-looking contraption that you're calling a mouse. So when I use things like the Green's Word Memory Test, I give more than usual training on how to use the keyboard, how to use the mouse. I also stay in the room to make sure the patient can read all of the stimuli that are being presented. Make them read it out loud to make sure that they've encoded the information correctly. And some of my colleagues actually stay in the room throughout the entire test. I do not, but I do stay very close by, as I often find they tend to get stuck midway, or they may even just stop responding altogether. I've even had patients just break down crying because of the negative feedback they get from the computer telling them over and over, wrong, 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 wrong. It really turns them off. The informality of the entire process, it just leads to them disengaging from the testing, and of course that doesn't serve my purpose. My purpose is to get their best test performance, and in general, you know, it's just a problem with floor effects when it comes to these tests. So I do try and use them sparingly, but I do recognize their value as well. Next slide. Here is a list of tests that I use frequently and where to find them. There's pros and cons to each and every one of them. Let's start with the effort test. Use effort tests with caution. Keep in mind that cutoff scores may need to be lowered. IQ tests tend to be regional. There's LACE options for Puerto Rico, for Mexico, and for Spain. They each have their pros and cons, but I've actually started using the Woodcock-Johnson cognitive battery because they have a nice 3 subtest option for prorating IQ, which is a nice dirty measure for getting the numbers that I need. I like to use the DRS with my geriatric patients, the dementia rating scale, but you need to request special permission from PAR to use the Spanish version because it's not, you can't just go online and order it. You need to request special permission, and they only give you 20 at a time. The last time I renewed, my contact person was Vicky Fadden, and her email is included there if you're interested in getting permission to use this scale. Norms are available. The following 4 batteries are ones I use with younger adults. Now they're listed in order of shortest to longest, with the Neuropsy only taking about 30 minutes, and the Neuronorma battery, if you did all of the tests, could take up to 4 hours. Now I only administer select tests from the Neuronorma, and usually only for my geriatric population, as I think they have best norms for older adults. These norms were modeled on the MONES data set for older adults. And on top of that, they're free. The disadvantage of these norms is, as I've stated before, they're developed in Spain, so may not be appropriate for our population. The Myers battery is a very young and highly educated sample of mostly Mexicans from Mexico. The advantage to that data set is that it's the same battery as I use with my English patients. It's easy to administer, easy to analyze, easy to write the report with the program, but it is a very small sample and they're very highly educated, so not consistent with the population I mostly work with. Artiola's Batería Neuropsicología en Español is perhaps the best suited to my population. It has norms for Mexicans from the US-Mexican border region as well as Spain. They offer an analog to the WIMS logical memory and visual reproduction, which have train 2 criteria. That means that the stories and pictures can be presented up to 5 times to ensure that the patient encodes a sufficient amount of information. It's a little lengthy to administer, but I feel like I get pretty good data from it. Finally, there's the mood questionnaires and inventories. I'd caution that with some folks, they're confused by the concept of a Likert scale or even multiple choice. So make sure that they understand it, or you could even administer it to them in interview format. Next slide. So by looking at how patients do things, I have to say it's often more telling than their actual test scores. Dr. Judd will tell you, don't get caught up in the tests and the numbers. A lot of people, they just see the numbers, and we're trained in charting things on the normal bell curve, and that just doesn't work as well in these cases. I want you to try and imagine how you diagnose someone if you had no tests and only $1 change to your name. What would you do? What kind of information would help you? Well, you could have them flip a coin like Ted showed us, or you could even have them count pennies like my friend Caterina Belen does. She uses the penny counting to tell us a lot about her patients' executive functions. So do they count the pennies one by one? Do they group their pennies into groups of 10 or 5? Do they lose count? Do they lose track of their strategy? there's a lot to be said, about using what you have at hand. And one thing I learned working in a very poor community center in Puerto Rico was that your best tool is you. When you have no tests, the best tool are your own professional skills. So let's move to the next step, step 9. Now, whatever tests or measures or observations you're going to use is all going to have to be documented in the report. Several supplemental documents have been provided in how to document issues, such as whether tests were administered in a non-standardized fashion, what kind of norms were used, were interpreters used, other factors that may have also interfered in the evaluation process, other observations, qualitative observations. So let's see, when deciding what language to write your report in, most of us will not have an option and will have to write the report in English if you're in the United States. And no matter how good your language skills are, I doubt that you're also going to have the time to translate that entire report into another language. So hopefully your institution will have a translation department that can do this for you. Where I practiced, the entire report was translated, but now we've decided to reduce that to just the summary and recommendation section, since that was the part that was the most relevant and useful for patients. Of course, they can request the entire evaluation if they like. I try to base my recommendations in that patient's reality. So I won't recommend computerized brain training exercises for someone who doesn't have or doesn't want a computer, but I will encourage traditional healing approaches, things like herbs, sweat lodges, whale blubber. I mean, depending on the person's background, there can be all kinds of alternatives. I like to ask patients to let me know, as well as their other providers, to keep us up to date about what kind of rituals or substances they may be using, because they can interact, or in the case of certain herbs, they can even be toxic if they're not prepared properly. So I like to know about what my patient is taking. I also make a point to try and refer patients to other Spanish-speaking providers whenever possible. I also give them educational information in Spanish as well. I also try to make the summary as clear as possible. So in many cross-cultural neuropsychology reports, you'll find that usual disclaimer that the findings are influenced by linguistic and cultural factors, and that making a clear diagnosis was difficult, or at least you should find some mention of it. The person writing the report was sensitive to these issues. But perhaps more so than in other types of assessments, in these type of assessments, we may risk the problem of being too vague. And I'm going to speak for myself here, because I think when I first started, I was overly conservative. And I say this because for my very first Spanish assessment that I did as a solo provider, that was the only report where I got calls from other providers asking me, what did you mean in that report? Like, what did you mean when you said this? Or what were you alluding to? This was a citizenship exemption case. The results, I had decided not to endorse the application. So naturally, the patient went to several other doctors who for months afterwards were contacting me, asking me for clarification. And in my mind, I thought it had been sufficiently clear, but apparently there was still some doubt, perhaps because use of this guarded disclaimer statements that I had been trained to tack on to all of my reports. And at that point, I realized that I was about as clear on this case as I would have been had the patient been in English. And I sure don't put disclaimers on all my English reports. So I now try and word my reports to better reflect my certainty. And if there is diagnostic uncertainty, I focus then on what this is not. Now, perhaps I was a unique case, but all I know that is, for better or worse, I no longer get those calls, which I hope that means that my reports are about as clear as they can be for both providers and the patients. Next slide. Now, we do have to talk about billing. We all know that time means money. So by logic, these assessments, which take longer, should be reimbursed as such, correct? Well, that's wrong. The reality is, unfortunately, that the medical industry is facing a 20 to 40% reduction in reimbursements. Insurance providers are trying to cap off reimbursements for neuropsych evals anywhere between 4 to 6 hours. Thanks to advocacy by our fellow neuropsychologists, in IPAPO, the billing models are now moving away. They've actually allowed for 8 hours of testing as a cap. I do have to say that supportive documentation is needed when you do any testing that surpasses 8 hours, so you have to justify why you did more, but at least we have those 8 hours. If you do surpass those 8 hours regularly, you can anticipate being audited. And in general, I think our billing models are moving away from a pre-authorization model to an audit model. So what do you do when your evaluation is over 8 hours? Well, you have to consider, one, if you're billing for things appropriately. If you're doing a lot of literature and review background research, you only want to, I typically don't bill for this because I use it and apply it to my other cases. But the only way you can bill for this is if you're doing some very, very specific research that is very specific to this patient, this case, and would likely not be used for other cases. But other than that, I typically do not bill for my literature review and background research. And, you know, you say, well, you know, sometimes it's easy just to do the work pro bono. Depending on where you work, you may need to consult with your institution prior to offering pro bono services. Beforehand, the billing department usually will try to help set up patients with a payment plan or charity care, and they'll want to be involved in terms of accounting for your time. So important to keep your institution updated about that. Next slide. Finally, step 10, self-evaluation. For 50% of Hispanics, their first visit with a psychologist is sadly their last. Why is that? Dr. Judd identified several issues why this may be, but he also asked the question, what can we do to change that? Well, first of all, I think that we can recognize that the neuropsychological evaluation process can be very intimidating for our patients. I try to make a point to thank all of my patients for their time, their hard work, their patience. I tell my clients that this is a new clinic, a new service, and that they're playing a role in making it better by giving us their feedback. I ask the patients what works, what doesn't. This all helps to get a better idea of how I can best meet their needs. And by listening, you empower that patient to advocate for themselves, thereby improving services for their patients as well. Next slide. So whether we like it or not, culture's in our brain. It's how we shape our world. So multicultural competence skills should include things like developing an awareness of your own cultural values and biases, learning to value others' worldviews, developing a set of culturally appropriate and personal skills, and by doing so, we could become more culturally responsive and are better able to understand how cultural factors shape the brains of our clients. Dr. Mayo said, once you start studying medicine, you never get through it. And I think that the same applies to neuropsychology, especially if you're doing cross-cultural neuropsychology. If you never stop learning, you become a better advocate for your patients and a better teacher. You will be faced with many ethical challenges in this type of work, but if you always remember that the patient's needs come first, and I repeat that, the patient's needs come first, that will guide your way. Here's a summary of the 10 steps that we covered tonight. Next slide. It's telling that most of the steps involve preparation before you've even seen the patient. The actual testing portion is actually one of the last steps. I'm hoping that this information provided to you tonight will give you what you need to hit the ground running, and I'll help you anticipate and avoid many of the road bumps and potholes that I encountered along the way. I can tell you I pretty much stumbled my way through these steps, and this webinar is just a result of my reflections on how I could have done it better. Now keep in mind these steps are guidelines. Can be approached in any order, and when you do hit those bumps, know that I, as well as Dr. Judd, are available for consultation. Next slide. I'd like to thank my co-presenters, Ted, April, Octavio, and Priti, for dedicating their time to turning these ideas and thoughts into an action, into a webinar. I also thank each and every one of you who turned in to listen. We definitely need more neuropsychologists like you who are interested in doing this type of work, working with these types of populations. In fact, our clinic in Madison, Wisconsin will be looking for a couple of good neuropsychologists to join our team in the very, very near future. The position has not yet been formally posted, but if you're interested and would like more information, please feel free to contact me. There's my email, or you can send me your CV. With that, I'd like to hand over the floor to Preeti, who's going to be moderating our question period. Thank you very much.
Thank you very much, Dr. Castro, for this great presentation. We'll now start our Q&A. Preeti will read your submitted questions and ask any of the speakers to answer them.
Okay, so we had a couple of really great questions. The first question to the speakers is, in the absence of culturally appropriate norms, to what extent would one recommend qualitative versus quantitative analysis?
Ted, I'll let you take that one.
Yeah, okay. Actually, I've been reviewing all of the questions while you've been speaking, and I think if I take a few minutes, I can address about half of them, because they kind of group together in certain ways, including this one. I'll start with a very brief story. In 1988, I was teaching neuropsychology in the Lenin Fonseca Hospital in Managua, Nicaragua, and there was a neurosurgeon there, Dr. Fonsetti from West Berlin, who said that when he went to conferences, people asked him, how can you do neurosurgery without a CAT scanner? Because Nicaragua was very poor, they had no CAT scanner, and he said, we're very good neurologists. And I mentioned before about how doing cross-cultural work really puts you on your toes about all of your skills. Testing plays a role, yes, but it's all the other skills that are so important, and that are so important in this work. And before you get to testing, you ask yourself, not what test should I use, but what question do I want to answer? And how can I answer that question? And to what extent do tests play a role in answering that question? So sometimes you don't have tests that can answer the question you want to ask. But when you really focus on your questions first and look for the information you need to answer that question, it may come from interview, it may come from talking to a collateral from one family member or another family member, it may come from observations. You may be able to figure out that you can get an answer to that from qualitative testing and from non-standardized or testing the limits. Or you may say, well, I have this test that can get me close enough to the answer that I need for this particular purpose now. That same principle, what is it I want to know, helps you and guides you in which language do I test in for a bilingual. If you want to know how they're going to function in an English-speaking environment, then you probably want to test them in English. If you want to know diagnostics, you probably want to test them in their first language, etc. So you use the question to guide your decisions about how you go about the evaluation. The evaluation, not just the testing, but the whole picture of the evaluation. And you stay alert to all of those things. And for a little more guidance in that way, there were several questions, somewhat technical questions, some of them including, will we get the slides? Yes, the slides are available. And questions about resources of various types and norm bases and so on. And I hope people here can see the slide that I just did screen share, that they can see this list, which in addition to the slides, there's a file of about 20 pages of resources that you will be able to link to it. And this is a list of the table of contents of those resources. Several people asked, how can I get further training? And number one here partly addresses that. This is a list of, I have a list of about 20 different possible learning objectives in multicultural clinical neuropsychology training. You can consider it a menu, and if you're a student, I would say, look at that menu, pick out the things you would like to learn, make a list of them, and take them to whoever's responsible for your program and say, here's what I'd like to learn. How can you help me learn it? Remember, you're the customer. Can I learn that here, or do you have to send me elsewhere to learn it? Or can we hire some outside consultancy to help me learn it? Or can we set up a program to learn it? Someone was going to say something?
Oh, no, I'm sorry, Ted. I was just going, please finish.
Oh, okay. Also here, there's a cross-cultural psychological evaluation checklist for you, so as you approach a case, you can run down that and see, have I got the resources I need, am I ready to roll, and so forth. I mentioned that there was some discussion of your own second language skills and how to use them. There's sample language to use in reports, and the semi-structured interview questions that I promised you. The rest are the other resources that folks asked about.
I just,
Yes.
I'm sorry. I just wanted to add to that, and joining listservs, as what was mentioned by Dr. Castro and yourself, is also another way to find out about resources. There's about 330 members on Society for Clinical Neuropsychology Ethnic Minority Affairs listserv, so that's one way you can post questions, and there are access to those who are interested in cross-cultural issues that can help address those. I was just going to add that.
Okay, thank you. There was also a question about the CFI, the Cultural Formulation Interview of the DSM-5. And very quickly, the main points that I would have to say about that is that it's very good because it makes accessible various kinds of interview questions and brings it to the fore instead of relegating it to Appendix I in the back of the DSM. It's also flexible and has specific units for specific populations. And it includes questions about cultural self-awareness for the clinician. That's the good news. The bad news, from my perspective, it's still a Western individualistic presumption that you're there in a one-on-one interview, and it also presumes that you can ask the client to give you insight about their own culture, and they will be self-reflective about it, and that you haven't done any of your own work to learn about that culture or to be able to bring to the process. That's my main and primary difficulty with it and the main limitation. Of course, it's for psychiatry, not neuropsychology, so it's missing a few pieces there. But that's the main part of it, the main limitation. And to finish my kind of global response to many of the questions, I want to emphasize again the idea of researching the culture of the person before you ever see them through ethnic profiles and other means, but also after you've seen them. Go back to the interview, look up their hometown, look up the funny symptoms they told you about that you were unfamiliar with, and the funny drugs that they've been bringing from home, and the rituals they told you about, and all those kinds of things. And with all those kinds of techniques, which are not, they're not rocket science, they're not brain surgery, they are relatively easy things to do with lots of resources available on the internet. You can do a much better job than just going in there and faking it. I think that's about, that gets to, there were a lot of questions about test resources, and many of them are listed in the handout. So let's proceed from there. Thank you. Other questions you want to field?
Dr. Castro, do you want to add anything?
I think Dr. Judd really covered it. He did a great job. You know, I think having trained in Puerto Rico, that was an incredibly valuable experience. And if you have the opportunity to do a practicum, do a summer internship, do a rotation in any foreign country that requires immersion of your language skills, immersion in a culture, if it's Doctors Without Borders, volunteering, whatever it may be, I think that both personally, it assists with your personal growth, but also with your professional growth as well. I think that has been probably the most meaningful experiences for me, is working with different populations in different countries than, you know, any of the tests I learned or anything of that sort.
I didn't fully address some of the testing questions there as well. And I'd say as a general rule, if you've got somebody with more than 6 years of education, there's a pretty good chance that you can get some fairly meaningful information out of normative-based testing. But we have to remember that normative-based testing is only one form of inference that comes from testing. There's also comparing the person to themselves, one side of the body to the other, how they do now compared to how they do later. Qualitative features, how they respond to testing the limits, and various things. When you're working with people with less than 6 years of education, you have to rely increasingly on those other means of inference rather than normative-based. And there's an asymmetry of interpretation. If they do well on the tests relative to norms, you can have some confidence that they do well at that. If they do poorly, you're not sure if it's because of brain injury, or if it's because of culture or not understanding what's going on, or motivation, or any number of other things. So it can still be worthwhile to test, but you may have an asymmetry of interpretation. There's also a question about when do you take culture into account and when not. Well, again, what are you testing for? Why do you want to test? Let's take the driver's license road test for it as an example. That's something where we want an absolute standard of ability. We don't want to have somebody come here from England and they go out for their road test and they start driving down the left side of the road and you say, oh, well, that's just a cultural difference, so it's okay, so we're going to give them their driver's license. I don't think so. Or say, well, they're 85 years old, and according to the norms that we have, they're still at the 20th percentile of stopping time for an 85-year-old, so that's okay for the road. Maybe not. Maybe we don't want them out on the road anymore. Consider what question do you want answered? What kind of standard do you want? And what's the purpose of your testing?
Yeah, I can add to that one little thing that I like to do. It's not a formal test. It's no norms. It's just a little measure of prospective memory. So when the patient comes in, they usually have some personal belongings, either a jacket, purse, cell phone, whatever it may be. And I like to say, oh, let me take those for you and put them in a safe place. And then I let them see where I put them, whether in a cupboard or on top of a shelf or wherever it may be. And then we test throughout the whole day. And at the end of the test, I forget to give them their belongings before they leave. Now, the ones who have true memory problems will just leave without them. In fact, they'll leave everything behind, and they won't even notice it. Generally, the ones that don't have memory problems are the ones who are, oh, I need my cell phone, because they can't live for too long without the cell phone, and of course they have no problem remembering the PIN to get in the cell phone to check on Facebook. I know those are silly little things, but they're telling. They tell me more about what this patient's reality is and what their functioning is. I like to do a lot of conversational investigation. So if I'm talking to a patient, I'll ask them, oh, so what do you like to do? And if they like to cook, I ask them, oh, what kind of things do you cook? If there's some very, very complex Mexican recipes that if you have a memory problem, you're going to forget the ingredients, you're going to forget the order. I mean, they're very challenging to do. And if you find that the family member is not making the family's favorite dishes anymore and can't really explain why, I mean, those are all telling as well. Whereas, if it's something more along the lines of accidentally mixing up the salt and the sugar, I can tell you that I've damaged many meals that way. So, that's something that's more benign. If the person likes playing cards, have they noticed that they're having difficulty playing or remembering the rules, keeping track of things like that? And when you talk about individuals in the more of a conversational way, they tend to open up more and let their guard down and tell you more about their life, because it just seems that you're asking them about them and you want to know more about them, as opposed to testing and evaluating them and making them justify themselves or explain themselves. I think people are much more receptive to that, and I get a lot of really good qualitative information from that avenue.
To add to that, Melissa, in my interview, I divide my semi-structured interview into what I call review of neuropsychological systems, which is our traditional sensory perceptual, motor, praxis, attention, memory, language, visual, spatial, emotional, etc. And then review of functions, in which I ask about ADLs, education, employment, money management, transportation, recreation, spirituality. I have that divided into 13 different categories, and I make my students memorize those 13 categories. And we do a whole separate interview on that, which yields an abundance of useful data that is very helpful, especially in cross-cultural kinds of settings. And then you can always ask, if you don't have a kind of internalized sense of that, and compared to how they were prior to the illness or the injury or whatever, how are you doing at those things? Or compared to others the same age. So those are among the qualitative tools that I use for that purpose.
What about you, April? What do you use?
For Well, you guys said a lot of the things that I would do. I think mentioning about what people like to do, and I'm just thinking about this, keeping in mind that we should be doing this for everybody, regardless of their, language proficiency. I think just across the board, a good neuropsychologist is trying to get an assessment, particularly of what someone likes to do. And when we're trying to think about functional impairments, I work with populations that often, they sit around all day and they don't do much. They, watch TV and that's about it. And so when you're trying to do an assessment of functional capacity and ability, sometimes that data is obscured if somebody doesn't do those things on a regular basis. So really individualizing it and trying to figure out, getting a good qualitative interview about what you do on a normal basis, which you basically said, I think is really important.
So Caterina Belen was also the one who told me about her penny counting test. She also recently told me about the analog for the Tower of London test from an old ranchero from Aguadulco. So he said his father gave him the following riddle as a child. So there's a wolf, there's a sheep, and there's some alfalfa. Now your job, the ranchero, is you need to get all three of these across a bridge, but there are rules. You can only carry one thing at a time, and in no point in time can the wolf be left with the sheep, because obviously the wolf will eat the sheep. And at that point, in no point in time can the sheep be left alone with the alfalfa, because he's going to eat all the alfalfa. So what do you do? I thought that was hilarious. Jokes aside, any other questions that we haven't addressed, or any new questions that have come up from some of the issues that we've discussed?
There's a question I'm looking at that it is about norms, but they're asking about how can one determine to what extent the performance was affected due to cultural differences? And that seems to have a lot of lights to that question. So, and I think that is an interesting question that I struggle with in neuropsychological data, is when you're looking at it, how do you parse out, the low education versus this is just poor performance. And we know that years of education, there are limitations to that, and a lot of the work that has been done looking at educational quality has tried to tap into that. And we sort of try to give interviews about quality of education. So I ask a lot of questions about access to books, what did they have in the home growing up, what type of access to books do they have now, what was their educational high school, middle school like in terms of facilities and resources. So that's one way I've tried to go about it, but in terms of actually separating out the variance in the test data, maybe one of you can speak to how you go about that.
Okay. Yeah, it's a couple of questions, and you mentioned about asking about access to books and things of that sort. I'll briefly mention, and in the materials there's reference to a relatively new questionnaire called the Premorbid Cognitive Abilities Scale, developed in Brazil, particularly for those populations of people who have had limited formal education but have educated themselves, which is often especially true in countries where there's not much access to education and where there are languages with transparent orthographies where it's relatively easy to learn to read without formal instruction or with limited instruction. And they ask, it's a questionnaire that asks about how often they read and what kinds of things they can read and what kinds of things they can write and what kinds of math skills they have in everyday functioning. So I recommend that for another tool in that regard. To what extent culture itself influences, well, it influences the evaluation overall in many, many ways. if we get very North American about it and focus on its influence on tests themselves. That's certainly an empirical question, and one on which there's not a whole lot of research that really is able to tease apart the influence of culture versus the influence of education and quality of education versus language. Some of the few studies that look that way have looked at a multicultural immigrant population of folks who were bilingual in English and some other language with university students in the United States or university graduates. So they had been competent in English at a university level. And findings were roughly that on things like coding, attention tests that are speed of information types of tests, their performance most closely resembled the population of where they got their high school education. Which is to say, if you came to the United States after high school and got excellent English here, maybe even learned English back at home and then continued it here and got a university education here, you still performed closer to your population back home. But if you came before high school and got that part of your, or earlier and got that part of your education here and you were bilingual, that you more closely resemble the U.S. population in your performance on those kinds of attention tests.
I
high school
I don't go ahead.
As a rule of thumb with regard to which normative group and how to interpolate between groups.
I was going to say, I don't think you can parse out culture from any evaluation you do. I think 100% of the evaluations you do have some cultural component to them. I could say that every single assessment I do is a cross-cultural assessment because I'm assessing predominantly Caucasian Americans, which is not my culture. I'm not even American. I know what my patients are going through because I haven't done any of the citizenship process. I'm going through it myself. But, you know, if I had to look for norms for someone giving me a neuropsychological assessment, what norms would they use? What language would they use? It doesn't exist. And nowadays, our population is so multicultural. The cultures are blending, the languages are blending, the exposures that we have to different belief systems, religious systems, from every component that exists for diversity, I think that we are all having more exposure on all these levels. And as such, technically, there isn't an appropriate normative data set for any single one person in this entire world. We all come with our own collection of experiences, places we've been to, things we've been exposed to, and as such, the answer would be that culture is present in 100% evaluants, and you'll never be able to tease it out. What you got to do is try and be receptive to it and see how it could have potentially influenced either negatively or positively in the assessment process.
Yeah, no, in my lab, we recently, we've been looking a lot at trying to get information about what school people went to and actually looking it up and trying to get some way to quantify the quality of that school. And it's been very difficult because if you look at the national rankings, it's based upon SAT scores and, you know, more measures of testing to actually rank the school system, because we thought, well, if we can get an idea of where they went to school, because someone tells you, I've had 12 years of education at, you know, but we don't know the quality of the school, and they don't really know, because it's really hard for people, I think, to do a self-assessment of their educational quality. You know, you definitely culture permeates all throughout testing, but really trying to get those low-quality metrics. So we have been finding pretty much, you know, the reading test, like the RAT, has been correlating pretty well with what people have said their educational quality is, those that are able to provide a decent assessment. But I do think we need to get at least better at somehow with the educational quality, since it does impact performance so much.
You know, there's a new movement in collecting norms and analyzing norms. That now there's this initiative that looks not just age, you know, all the usual suspects that we're used to, but also cohort. So what is your life expectancy? So norms based on what year you were born, what generation you were born to, and what your life expectancy is based on that specific cohort. So not just when you're born, but when you're going to die. I mean, that's just, for me, it's astounding.
Yeah.
A normative set on how long you're expected to live.
Oh, no. I don't want to know.
There were a couple of questions that concerned LGBTQIA populations. And in that context, I want to go back to a concept I touched on very briefly at the end of my presentation concerning triage. And this also has to do with the question of which norms and how much culture applies and so on, in the following way. That much of the work that I do in cross-cultural work, the questions are pretty big. And I can answer those questions pretty rapidly and pretty easily in a way to move the person's interests forward, to serve the needs of the patient, without having to do the fine-grained analysis that looks at exactly how many standard deviations above or below the mean of which group they're in. We're looking at moderate to severe injuries or conditions of one sort or another, or dementia. It doesn't need the stats of norms to bring out what's important. And I would say that that's that one of the questions was with regard to LGBTQIA issues, how that intersects and manifests in working with my clients. I think that when it comes to neuropsychological issues, that is determining the larger variables of brain disorders and their impact on life overall. In my experience, because I'm doing triage, looking at kind of big, broad stroke issues, that's those kind of dynamics are fairly irrelevant to the brain functioning issues per se. However, they are, of course, tremendously important to understanding who the person is, what their life experience is, and what kind of recommendations and what kind of treatment might go forward from here. So I would say that those issues can be very important, but they're important more at the clinical psych level than at the neuropsych level, at least at the populations that I work with.
There has been some issue on the listservs looking at perhaps some hormonal changes or specific sex differences that need to be taken into consideration when we're looking at certain individuals in the LGBT population who have decided or who are taking hormone therapy or who are deciding to do sexual reassignment surgery. And I know that that has been an issue in looking at transsexual individuals, whether there are appropriate norms for them, and what do you use? Do you use biological male or biological female norms for these individuals, and at what stage in their process would each be more appropriate? The answer to that, I do not know. It's really hard to say, but I think that from a broad standpoint, the sexes, both male and female, are probably more similar than they are different.
Okay. All right, we are definitely running over time, but we would love to thank our speakers, Drs. Judd and Castro, for volunteering their time to make this webinar possible, as well as Dr. Thames for putting together this fantastic webinar. We also would like to thank our viewers for joining us. We hope you'll found this information useful, and we kindly request you to fill out a brief and anonymous online survey to give us feedback. Your input is very important to us, as it would help us improve the future webinars as well as identify relevant topics to better meet your needs. Finally, this webinar and other materials will be available on YouTube and on the ANST website. Thank you so much. Bye-bye.
Thank you.
Thank you.